Hello, nurses. Let's talk about drugs that affect the endocrine system. And my computer is setting new records for slowness. So this will be about pituitary and thyroid medications. So the endocrine glands include the pituitary. When it comes to the anterior pituitary, you could include the hypothalamus, since it regulates the anterior pituitary through releasing hormones. The thyroid, the parathyroids, which are embedded in the back of the thyroid and regulate calcium homeostasis. The adrenal glands above the kidneys. The adrenal glands consist of an adrenal cortex that secretes glucocorticoids and mineralocorticoids, and also androgens, and then the gonads, and then the pancreatic islets. We'll talk first in this presentation about the pituitary gland and medications for disorders of the pituitary gland, and then drugs that address disorders of the thyroid gland. So the first pituitary gland disorder I'd like to discuss are disorders of growth hormone secretion. Growth hormone secretion excesses during childhood can cause gigantism, and growth hormone excesses during adulthood cause acromegaly, where the skeleton does not get bigger, it gets bulkier, and soft tissues get bulkier too. This is often treated with surgery of the pituitary. This is called transsphenoidal transection. Medications that can be used in combination with surgery or used before surgery include these three medications: octreotide, lanreotide, pegcivimint. Octreotide, as you can see, is given subcutaneously and intramuscularly. Lanreotide and pegcivimint are both given subcutaneously. So octreotide pretty commonly causes gastrointestinal disturbances. If you take it on an empty stomach and at night, that will tend to relieve these symptoms to some extent. These symptoms also tend to abate after 1 to 2 weeks. The other issue with these drugs is a disruption of blood sugar. So you need to monitor the blood sugar regularly. Octreotide is also used to treat severe diarrhea and flushing associated with metastatic carcinoid tumors. That's the other use for octreotide. Lanreotide also causes GI disturbances, but unlike octreotide, it has a higher tendency to cause gallbladder stones. And the patient should notify their doctor if these symptoms become severe. This drug also will cause disruptions in blood sugar, so the blood sugar should be monitored quite well. You should use this drug with caution in people with gallbladder, liver, or renal disease, in patients with diabetes, hypothyroidism, and cardiac disease. This drug is not safe during pregnancy. Pegcivimint also causes GI disturbances. It causes hypoglycemia. So monitor the blood sugar regularly. Show your patient how to do that. It can cause liver damage. If icterus appears, you stop the medication immediately. It can cause chest pain. Patients should notify their doctor right away if these symptoms appear. And they can cause flu-like symptoms, but if they're a sign of infection, the patient should call their doctor. Opioids can reduce the effect of pegviscement, and it should be used cautiously in patients with diabetes, pituitary tumors, or neoplastic disease, or in patients with renal disease. So monitor for symptoms of gallbladder disease. Discontinue the medication promptly if there are signs of gallbladder disease, high bilirubin, Murphy sign, things like that. Glucose levels, monitor them regularly. Adjust medication as needed. Thyroid function, assess thyroid stimulating hormone levels, and if necessary, free thyroxine levels. Look for signs of hypothyroidism. Look for signs of disrupted cardiac function, bradycardia, arrhythmia, conduction abnormalities. Monitor using an ECG regularly. And then with nutrition. Monitor absorption of dietary fats because octreotide can alter the absorption of dietary fats. B12 levels can go down because of disruptions in B12 absorption. For patients on total parenteral nutrition and octreotide, they should have periodic monitoring of zinc levels. If B12 absorption becomes an issue, you can have them use the sublingual B12 vitamins that are made available by Celebrate Vitamins. These are available on the web. These will bypass the GI tract, and if you have problems with B12 absorption, these products work quite well. These were designed for people who've had bariatric surgery, but they work well too in people who are taking octreotide. If a patient makes insufficient growth hormone, they will suffer from dwarfism because that dwarfism is due to inadequate secretion of a pituitary hormone. It is often called hypopituitary dwarfism. Other conditions that will require treatment for short stature might include Turner syndrome, that is in females with just one X chromosome, people with AIDS wasting syndrome, and people with a genetic disease called Prader-Willi syndrome. The drug of choice is somatotropin. This is a genetically engineered product. It's genetically engineered growth hormone. So this is given intravenously or it's given subcutaneously. You look for signs of hyperglycemia because growth hormone causes a glucose sparing effect. You also get mobilization of calcium. So hypercalciuria, which can lead to kidney stones, is a problem. So look for signs of kidney stones, measure calcium in the urine, look for crystals, order the labs necessary for that. And glucocorticoids can counteract the effects of this drug. So monitor blood sugar regularly, adjust insulin doses in the case of diabetes. Look for signs of diabetes, hyperphagia, hyperdipsia, polyuria, hyperglycemia. Look for those signs, treat them if necessary, and contact the primary care physician. For calciuria, monitor patients for the signs of kidney stones: flank pain, fever, dysuria, hematuria. Report these to the physician. And if kidney stones occur, you might recommend that they start increasing their intake of citrate in juices, or you can just get lemon juice. You can put lemon juice in your water. That will tend to grab calcium and dissolve kidney stones. So contraindications for taking growth hormone include those who are severely obese, those with severe obstructive sleep apnea. Growth hormone will make it worse. A sleep test might need to be ordered. Use with caution in diabetics because of hyperglycemia. Use cautiously in patients with hypothyroidism, and the thyroid function should be regularly monitored, and signs of abnormal thyroid function should be asked about pretty frequently. Stop treatment in children prior to closure of the epiphyseal plate. You may need an X-ray or some other imaging to ascertain the status of the epiphyseal plate. So your job as the nurse is to get a baseline height and weight, then continue to monitor growth changes during treatment. Increased growth, of course, is a sign of treatment working. And then administer the medication as directed. Take the vial and shake it. If it has particulates in it, don't give the medication. That means either the vial is contaminated or the protein has precipitated, in which case it's no good. And then rotate injection sites as needed. And don't inject too close to a scar or the umbilicus. And make sure if you administer the drug subcutaneously that the patient doesn't rub it afterwards. Moving now to the posterior pituitary. Diabetes insipidus is due to an insufficient secretion of antidiuretic hormone. This causes massive water loss that leads to severe dehydration, severe electrolyte abnormalities that can lead to cardiovascular abnormalities. And the treatment is synthetic antidiuretic hormone in the form of desmopressin and vasopressin. Desmopressin is given in an oral form, an intranasal form, that's very popular, subcutaneously and intravenously. Vasopressin, which is also used in the emergency room and critical care, is administered intramuscularly, subcutaneously, and by IV drip. These drugs work very well. So the patient, if they're used to drinking a lot of water, they can overhydrate. So have him or her limit their water intake at the start of therapy. Always use the smallest dose possible, and then work up as needed, if needed. And then monitor for signs of overhydration. Look for sleepiness. Look for signs of a pounding headache. Notify the physician if their symptoms become severe. Vasopressin causes vasoconstriction. That's why it's used for CPR to raise the blood pressure. And excessive vasopressin can cause pretty extensive vasoconstriction, leading to myocardial ischemia. So you want to monitor blood pressure closely, monitor the EKG for abnormalities, advise your patients to notify their doctor if they have tightness in the chest pain, or excessive sweating. That might be signs of a heart attack. Do not use vasopressin in patients who have coronary artery disease or peripheral artery disease, peripheral circulatory disease, or patients with chronic nephritis. Vasopressin is contraindicated during pregnancy because of its tendency to cause vasoconstriction. Desmopressin is safe during pregnancy. You want to use these drugs with caution in patients with renal impairment, since the risk of water intoxication increases. And don't use it in patients with creatinine clearances below 50 mils per minute. For drug-drug interactions, the anti-seizure meds, carbamazepine, and then the tricyclic antidepressants can increase the antidiuretic action of these drugs. On the other side of the coin, alcohol, lithium, heparin, and phenytoin can decrease the antidiuretic effects of desmopressin and vasopressin. So if you're using these drugs with vasopressin and desmopressin, use them with caution. Warn against drinking excessively. So monitor vital signs, monitor central venous pressure, monitor their water input and output. That may seem like kind of useless bean counting, but it's quite important. Monitor the specific gravity of the urine, and then laboratory studies that look at things like the blood urea nitrogen, the sodium, potassium, creatinine, osmolality of the urine, specific gravity of the urine. Look at the blood pressure and the heart rate. Those are important signifiers of water intoxication. In particular, headache, confusion, or other indications of water intoxication. If vasopressin IV is used, monitor the IV site carefully for signs of extravasation that might lead to gangrene. And if you use intranasal desmopressin, start with a bedtime dose. Once the nocturia is controlled, then you give a dose twice a day. So again, start low, go slow. Now let's move to the thyroid. Hypothyroidism includes insufficient thyroid hormone. Hyperthyroidism results from excessive thyroid hormone. So the treatment involves either thyroid surgery, where the whole thyroid or parts of the thyroid are taken out. In the case of hypothyroidism, synthetic thyroid hormone medication is given. And then in the case of hyperthyroidism, antithyroid medications are given. The drug of choice is levothyroxine. This is a synthetic version of T4. Liothrix was a combination T3, T4 product. That product has been discontinued. Used to be called Thyrolar. The company stopped making it because the evidence that it worked in certain populations of patients kind of evaporated. It seemed to work best in a population of people who had a reduced ability to convert T4 to T3. Studies have shown that benefit was illusory. So Liothrix has been discontinued. Levothyroxine really is a drug of choice now for hypothyroidism. This drug is available as a generic. It's very cheap. The caveats with levothyroxine is overmedication. So your signs of overmedication are very similar to the signs of hypothyroidism. anxiety, tachycardia, palpitations, altered appetite, that is, increased appetite, abdominal cramping, heat intolerance, fever, sweating, weight loss, and in females, menstrual irregularities. Chronic overtreatment can cause atrial fibrillation and increase bone loss and a risk of osteoporosis and osteoporotic fractures in older patients. Levothyroxine is safe during pregnancy. It's contraindicated in patients with thyrotoxicosis or adrenal insufficiency or immediately following a heart attack. Unlike what you read on the web, this is not a treatment for obesity. And patients who get a hold of it to treat their obesity are at danger of really causing themselves trouble. Use with caution in diabetics, in older patients, and in people with cardiovascular disease, because the drug will overstimulate the heart. Drug-drug interactions include certain foods. Usually take it on an empty stomach. Foods can decrease absorption. Bile acid resins will grab this drug, prevent it from being absorbed. So will calcium and iron supplements. And so will anti-ulcer agents. Drugs like omeprazole, levomeprazole, drugs like that, PPIs. So if you take those, space those drugs and your levothyroxine by at least 4 hours. Take the drug on an empty stomach. Anti-seizure meds increase the degradation of levothyroxine. So you might have to adjust your levothyroxine up. So monitor for the effects of levothyroxine. So anti-seizure meds include things like carbamazepine, phenytoin, phenobarbital, and then also the SSRI sertraline. And levothyroxine increases the breakdown of vitamin K. So it can mitigate the effects of warfarin. It increases warfarin effects. Therefore, you'll get a lowered INR. So you want to monitor the INR. Remember, INR needs to be between 2 and 3. 2 and 3. I got that wrong. I'm sorry. It will raise the INR. So if your INR gets above 3, you might want to decrease the dose of warfarin. Educate patients about the signs of bleeding, ecchymosis, bleeding of the gums, coffee ground, puke, lactary stools, bruising, petechiae, things like that. So monitor vitals, height and weight, monitor cardiac function, look for signs of cardiac excitability. Begin with a low dose. If that doesn't work, bump it up. Full effect may require 6 to 8 weeks. Monitor T4 and TSH levels. Look for decrease TSH levels. Normal TSH levels are between 0.5 to 5 units per liter. Normal T4 levels are 0.7 to 1.9 nanograms per deciliter. Emphasize to the patient this medication is not a cure. They have to keep taking it even after they feel better. And do not switch brands of levothyroxine without express directions from your doctor. That's very important. Drugs for hyperthyroidism include propylthiourea and methimazole. These are used to treat Graves' disease or thyroid cancers that may cause hyperthyroidism. So they produce a euthyroid state prior to thyroid surgery. They're used as an adjunct treatment to thyroid irradiation. They're used for emergency treatment of thyrotoxicosis. First line drug is methimazole. Next line drug would be propylthiourea. These drugs block the synthesis of thyroid hormones. They block the iodination of thyroglobulin. They block the oxidation of iodide because they inhibit the peroxidase. They block the conversion of T4 into T3 in peripheral tissues. So they block almost all aspects of thyroid hormone production. So complications, first of all, are hypothyroidism. The signs of hypothyroidism there are very similar to the clinical signs of hypothyroidism. Know them: drowsiness, depression, weight gain, edema, bradycardia, anorexia, cold tolerance, dry skin, menstrual irregularities in females. Educate patients on these signs, report them to their doctor and to you, the nurse. Reduce doses and temporary administration of thyroid hormone supplements might be needed in some cases. Other complications include bone marrow disruption, agranulocytosis in particular. So look for sore throat, fever, fatigue. Report these to the doctor. Monitor the CBC with differential at baseline and then periodically. Stop treatment at the first sign of agranulocytosis. Administer Neupogen to treat agranulocytosis. Neupogen is granulocyte monocyte colony stimulating factor. That will bump up the granulocytes. Propylthiourea also can damage the liver. So look for signs of jaundice, dark urine, light-colored stools, and elevated liver function tests. These drugs are contraindicated during pregnancy and lactation. Use them with extreme caution in those with immunosuppression or bone marrow disease or liver failure. These drugs increase the activity of anticoagulants. So monitor the INR and the APTT, adjust the dose of anticoagulants as needed. They also increase digoxin levels. So monitor digoxin levels, reduce the dose as needed. So as the nurse, you monitor vital signs and weight, input and output of fluid at baseline and periodically. Hyperthyroid patients should be given a beta blocker that will decrease tremors and tachycardia. Propranolol is the typical drug of choice. Monitor CBCs periodically and regularly. Look for signs of agranulocytosis. Look for signs of hypothyroidism. Educate the patient. Don't discontinue the medication abruptly. Avoid consumption of seafood and other types of foods that contain iodine, things like iodized salt, things like that. Take the medication at the same time each day. That maintains a constant therapeutic level, and it will decrease gastric distress. Therapeutic effects can take 1 to 2 weeks to be evident. Full benefit may take 3 to 12 weeks. Tell the patient to be patient. No pun intended. So look if it's working, look for weight gain, look for vital signs to return to normal, look for decreased T4 levels, look for the absence of hyperthyroidism. That would be the absence of anxiety, tachycardia, heat intolerance, fever, diaphoresis, weight loss, and menstrual irregularities. Radioactive iodine. There's iodine 131 and iodine 125. In medicine, iodine 131 is the isotope that's used. This is an oral medication. It's used for thyroid cancer, hyperthyroidism in those who've not responded to other medications. It's used also at low doses to visualize thyroid gland function. This drug is used to kill the thyroid. After this drug goes through the body, the patient will need to be on thyroid medicine. Complications include radiation sickness. So intense nausea and vomiting, the vomiting up of blood, that's hematemesis, epistaxis, that is nosebleeds. These become very severe, stop treatment, notify the doctor. Monitor anemia, leukopenia, thrombocytopenia. So that means you'll be watching CBCs quite regularly. That means you need a baseline. And monitor for hypothyroidism, intolerance to cold, edema, bradycardia, weight gain, depression. These drugs are not safe during pregnancy, nor are they safe during lactation. Do not use radioactive iodine with other antithyroid meds. Those antithyroid meds prevent the uptake of the radioactive iodine, and you want the uptake to be as efficient as possible. Stay at least 6 feet away from the patient who's on the medication, the radioactive. Also, tell the patient to make sure their family members, particularly children, stay more than 6 feet away from patients on this medication. Don't share food with them. Don't share bedding with them. Make sure their clothes are not touched by the children. Encourage increased fluid intake. That will flush the radioactive iodine through their system. Instruct patients to dispose of bodily waste per protocol. Have them adhere to that protocol religiously. Avoid coughing, avoid spitting, expectorating. Avoid taking sweat and wiping it on the wall or something, because their sweat and their fluids will all be radioactive. Now, radioactive iodine has a short half-life, has a half-life of 8 days. After 16 days, the amount of radioactivity is going to be very small. But during that time, radioactive iodine is very, very energetic. So you must have spouses, children, stay away from them. I can't emphasize that enough. You might, in fact, some insurance policies will have the patient get a hotel room, and they'll pay for a hotel room. And so the patient can essentially alert the staff about the radioactive bedding and then dispose of wastes per protocol while they're in the hotel room. And then the hotel room usually will have a protocol they'll go through. Usually the room will be sealed And then 2 weeks later, the staff will go in and wash the bedding and so on and so forth, because the radioactivity usually by then is so low. Best way to do this is get the patient to stay in a camper outside the house. That usually works the best. Or in a tent if the weather's nice, or something like that. Or way up in the attic or something like that. Basements are good usually for that as well. Non-radioactive iodine creates very high levels of iodide that will then reduce iodide uptake by the thyroid gland, thus inhibiting thyroid hormone production and blocking the release of thyroid hormone into the bloodstream. This is good for emergency treatment of thyroid toxicosis. This will develop a euthyroid state and reduction of thyroid gland size prior to thyroidectomy. That's primarily what it's used for. Complications here are iodism. This medication is quite corrosive. So you get sore teeth and gums. Teeth may even become loose. Frontal headache. The gums and mouth might be stained. Metallic taste, stomatitis. You get swelling of the glottis, whistling when you breathe. So teach clients to notify their doctor if they show signs of an overdose. The antidote is sodium thiosulfate. Use that to reverse the effects of iodine and assist with gastric lavage as needed in case of iodism. This drug is contraindicated during pregnancy. Sometimes this is administered to patients in the hospital before they undergo thyroidectomy. Sometimes, not always. So avoid foods and other medications high in iodine, sea salt, iodized salt. That decreases the risk of iodism. Also, supplements high in iodine should be avoided, things like kelp and what have you. Also, nori in food that's high in iodine, avoid it during this time. Avoid concurrent use of potassium-sparing diuretics, potassium supplements, ACE inhibitors, ARB. They increase the risk of hyperkalemia. So the nurse must monitor baseline vitals and weight, input and output of fluid, monitor those periodically, instruct the patient to take the dose same time each day, increase their fluid intake unless instructed not to by the physician. Patients with kidney problems will be told not to, but then have them make sure they get the maximum amount of fluid per day. Instruct patient not to take over-the-counter medications and supplements that contain iodine, and then instruct the patient not to discontinue the med unless instructed to do so by their doctor. So fortunately, non-radioactive iodine plays quite well with other drugs and is often combined with them. So to ensure the drug is working, look for weight gain, look for vital signs returning to normal, look for decreased T4 levels, look for reduction in the size of the thyroid, look for the ability of the patient to sleep and achieve and maintain an appropriate weight. Look for the maintenance of normal blood pressure and heart rate, and for them to be free of all complaints of hyperthyroidism. So that concludes the pituitary and thyroid. In our next installment, we will look at drugs that treat abnormalities of the adrenal glands and then drugs for the hypothalamus. If you have questions, please feel free to ask.